Hello and welcome everyone to our virtual town hall series, Connecting the Dots and Engaging Our Communities. My name is Tiffany Jones, and on behalf of OneLegacy, we are truly thankful for this opportunity to engage in meaningful dialogue and to inspire our communities. As many of you may know, March is Women's History Month, but it's also National Kidney Month. And I want to say that I am very honored to introduce a woman who has precisely made history as the first African-American female transplant surgeon, Dr. Valmo Skelteberry. Dr. Scantlebury currently serves as the professor of surgery at Texas Christian University and Medical School. She earned her medical degree from Columbia University. She completed her fellowship in training surgery at the University of Pittsburgh. And Dr. Scantlebury has been named multiple times in both Best Doctors in America and Top Doctors in America's list. She is a published author of her book, Beyond Every Wall, that documents her journey of overcoming adversity and knocking down barriers. And joining this conversation will be Tanaya Wallace, who is the founder and CEO of Crowd Advocacy and Donate Life Hollywood. Donate Life Hollywood is a project of the OneLegacy Foundation. And Tanaya helps humanity get it right. She helps harness the power of purposeful work. And Donate Life Hollywood particularly helps the entertainment industry tell authentic and inspiring stories about donation and transplantation. Most recently, as I mentioned that March is National Kidney Month, Tanaya oversaw the development of the Be Like Gina campaign promoting living donation in conjunction with CBS in their prime time show, Be Positive. So before I turn it over to Tanaya, I just want to say that as you see us three here on this panel having a discussion today, this is what intersectionality looks like. Three women from different races and different backgrounds with a common goal to save lives through organ and tissue donation. And so pushing that commonality forward is what I really think will help bring us all together and to bridge gaps. Please know we're excited for all of you that are joining this town hall today. We thank you for your support. And I want to let you know during the last 15 to 20 minutes of the town hall, we will have a Q&A portion where we will answer your questions. So please feel free to submit any questions that you may have. And Tanaya, I want to let's get this conversation going. Let's get it started.
Okay. Yeah, we're ready for our close-ups, right? Hollywood style here. Dr. Scantlebury, it's so lovely talking to you today, and I got a chance to kind of hear a little bit about your personal story. One of the things that we're doing with Donate Life Hollywood is really helping the entertainment industry to hear real life stories of donation and transplantation and of physicians, because honestly, they're better than anything that Hollywood makes up, and overcoming adversity is one of those key themes that Hollywood loves. It's the kind of story that wins Academy Awards. And I feel like your story is the story. It's just an incredible story of overcoming adversity to the point where you've literally written the book about it, right? You've written a book about how you've overcome that adversity. So I want you to talk a little bit about your own life, about being the first of a lot of things, and an immigrant to the United States, and how you've gotten here to be this incredible transplant surgeon saving lives.
Thank you so much, tonight. I thank you for that introduction and giving me that great opening. I certainly didn't start out to be a first, but I just was following my passion and my dream, and that was to become a surgeon. And that journey definitely did have some bumps in it, because I trained during an era where women were not seen as being your typical surgeon, and being a Black woman was even more difficult, because I was told I couldn't be a surgeon. That was not what was recommended for me. But I moved forward. There certainly were obstacles, and I definitely hit obstacles, but yet still I persevered. And that led me to meet some wonderful people who were other physicians and mentors who guided my path, and not only provide opportunities for me, but open up some doors so that I could go on to do my research, to go to University of Pittsburgh to do my multi-organ transplant fellowship there, as the first African-American female transplant surgeon. And at that time, actually, at University of Pittsburgh, there weren't any other females in general surgery when I came on as a fellow. So that was even a little bit disturbing, because I came from New York, from Harlem Hospital, where there are lots of people of color as far as surgeons, and that was, the norm. So yes, it was certainly a culture change. But during my career, I learned a lot about transplantation under the guidance of Dr. Thomas Darzo, met wonderful people, but also learned about the plight of African Americans as we looked at the numbers in terms of the discrepancy between people of color in the waiting list, waiting for organs, pursuing and encouraging organ donation through education. So that became a major focus as I moved through my career.
The Dr. Starzl, have you seen the Dr. Starzl documentary, Burden of Genius?
Oh, absolutely. I actually have a small role in there somewhere along the line.
Oh, well, great. Well, that the documentary received a DLH Inspire Award last year for its work. It really is fascinating, the beginning years of transplantation and how he moved that forward. It's interesting because I think about donation and transplantation about love, that really it is that pure expression of love. I actually get really frustrated when Hollywood keeps trying to put it in the category of just a medical genre, or then it tries to put it in horror or fear. It tries to scare us, Hollywood does. And I'm like, no, organ donation and living donation are about love. But for any one of us who's been in a relationship, we know that there can't be love without trust. And so I wonder if some of the things that you see and you were looking at when you were coming through the ranks and in your work, especially with people of color, when it comes to organ donation itself, is there an element of the trust that's missing within community color and the medical industry, institution in general? Could you talk about that?
Well, certainly, I think, and I have to give credit to Dr. Clive Callender, who started National MOTEC, because his early work was recognized, was done because of the lack of organ donation within communities of color, within the African American community, and looking at the fact that there were a significant number, while we make up 13% of the population, when you look at those in dialysis, and those listed for transplant, proportionately, you make up 30% or 33% of the waiting list, but the organ donation isn't matching that. And so his goal initially was to go out there and figure out what are the barriers, what's keeping people from donating. And the top on the list is always distrust of the medical community. Those stories of my grandmother going to the hospital and coming back and she was a donor and we didn't agree with it, or they died in the hospital. I'm afraid that taking my organs. So all that distrust has been there for many, many years. And this country does have those elements of it that created distrust. When you look at the history of treatment of African Americans in this country, not necessarily, but not only in the medical system, but just in the social structure and structural racism and all those elements. And so we do have a history, and we have to recognize that, and we have to own that distrust. We have to own that there is racism. There's racism within our own medical system. And that element of distrust can be validated, but we have to decide what do we need to do to eliminate that racism. How can we break that distrust? How can we move forward and explain? And it comes through education. The more we discuss these issues, the more we own that, yes, there's a fear, we recognize that fear. We're not asking you to eliminate that fear, but we're asking you to trust the system as it is now, because now there's a person of color who's here at the table who can talk about what it means to be a donor, that we're not going to take your organs. We're there to help you if you're injured so that you will survive. It's only after you cannot survive will there be organ donation. And that's where those conversations become important at a level that communities can understand and can grasp and feel like, okay, that makes sense, as opposed to what was their initial perception.
You talked a little bit about too, trust kind of in the system at large, and and those biases that are really, unchecked a lot of times, and how you've had patients who they see you as a physician and a woman of color, and there's like an immediate kind of like, okay, being seen, really
Right.
seen for their humanity, and that you've even had doctors who have looked at somebody who's on dialysis, a person of color on dialysis, who has said, oh, they won't make a good candidate. And what is your response when you hear that?
But unfortunately, we're not here to judge. And we're here to look at data, look at numbers, look at what the person brings to the table, and can we make them a better candidate?
Mm.
Oftentimes patients are written off because we say, oh, well, they are non-compliant on dialysis. What does that mean? Why are they non-compliant? You have to look beyond that. Is it that they didn't have a ride to the dialysis unit? Is it that they were sick? Is it that there were other things going on? So maybe there were other factors within their own personal life that limited their ability to show up. Or maybe they needed to go to work because their lights were turned off and they needed that last dollar to be able to survive, whatever it may be. So rather than passing that judgment, dig deeper, put yourself in that person's place, and have that cultural sensitivity to understand what is going on with this patient, as opposed to having that initial bias where you stereotype that patient into saying, well, they just fit into that category. Oh, the last patient that looked like him, didn't do this. And so you begin to lump patients under those stereotypes, and you have that implicit bias that moves you to act with those microaggressions to then discriminate against that person.
I love that, the simple question of, well, why?
Mm-hmm.
Why?
Right.
Just, yeah, explain to me, why do you see the person that way? And then why do you think that they've missed dialysis? Yeah, is it just they don't care? It's like, really? Is that why? So I think digging deeper into there. There are barriers to living donation in communities of color, as well as deceased donation. And Donate Life Hollywood is doing a lot on living donation, especially this month. We helped with a PSA on CBS, which actually led 14,000 people to go to the BeLikeGina.org page to find out about living donation. 25 people filled out a form that they are interested in being living donors. And one of the things we did with this very short PSA was we tied it to a sense of purpose, not necessarily like, hey, you can save somebody's life, but you can feel purposeful in helping other people. And I'm wondering if there's, is there things about living donation that is different than deceased donation when communicating to communities of color, do you think?
I think it's the whole concept of understanding or explaining that it's a gift. You can give that gift while you're alive, or you can give that gift upon your death by signing up to be an organ donor. But just imagine if you have 2 working kidneys, how important, how blessed that person would be to be able to say, I can give one of my kidneys to someone in need, to my loved one, to my dear friend who is sitting on dialysis, and being able to understand that you're helping, that your life is not going to be in danger. And this is where a lot of living donors are skeptical about what exactly is going to happen to me. But also you allow someone else a chance at a new leash on life. And it gets them off the waiting list. It keeps them from competing with those thousands of people in their region that are also waiting for a life-saving organ. And I think that's where education helps.
You mentioned something that I think would be great for all writers to know and to be communicating, because so many of the donation storylines that we're seeing on television right now are about living donation. And, it was like the Hollywood totally terrified people about deceased donation, and now they're going to start terrorizing people around living donation. And one of the things that you mentioned, and we're having a writers panel on Thursday. Anyone who wants to join, go to accessdlh.org/writers panel, and you can register for a writers panel. And we're going to specifically talk about conflicts, real conflicts inherent in the living donation process that writers could tell stories about. Well, one of the things that I think is so interesting, and it goes back to what you were just saying, the idea that getting people to not compete, right? Being able to preempt dialysis. And there's some understanding of that. There was something on The Good Doctor that kind of mentioned that, but the medical reasons behind that, I wasn't even very aware of. So could you talk about medically why it's so important to get people transplanted as early as possible and the health impacts of dialysis itself?
Oh, definitely. Unfortunately, we still see the fix for end-stage renal disease as dialysis as opposed to transplant. And understanding, yes, there are not enough organs out there, and not everyone will have access to a living donor. But if you approach the disease process and you're fortunate enough, and I say fortunate enough to be diagnosed early to see this coming down the pipeline, which for many people of color, their diagnosis is made so late in this stage of kidney disease that they they're diagnosed and needing to go on dialysis right away because it wasn't known. But if you have that preemptive knowledge of saying, now you're at stage 3 to 4 and you're headed towards stage 5, and now here are your choices, you can get a living donor and avoid dialysis altogether. And so here's the plan for you: find a living donor. Now you're no longer needing to compete with those 5,000 people in your area on the waiting list in those multiple hospitals in the region where you reside. And that person is given a kidney to you. It takes you out of that pool. And now you can plan to say, I'll work through Christmas, or my donor can say, I can't take off until Christmas, or during the summer if I'm a teacher. And now you said, okay, fine. I know my transplant will be scheduled in July, because that's when I will have everything arranged, and family, kids are all in wherever they need to be, as someone is going to take care of them. And you can plan your life around that, as opposed to the middle of the night or sitting on dialysis year after year. We know that avoiding dialysis and preemptive transplant patients do much better than those who sit on dialysis for 5 years and 10 years, because there's a higher mortality and death rate comes with long-term dialysis. If you think hemodialysis in particular, if you think of the consequences of having that machine filter your body and not making urine, and the progressive heart disease that comes with end-stage kidney disease, whether it's having diabetes or high blood pressure, or those who just had high diabetes develop high blood pressure, which is also a symptom of kidney disease. So if you didn't have high blood pressure before you develop kidney disease, you will have it afterwards. And so those things add to worsening heart disease. So now you need to make sure that you're having a good medical doctor who's going to control your cholesterol, monitor your heart disease, and keep you from having a heart attack, and keep your diabetes from causing heart disease and peripheral heart disease, because peripheral vascular disease and losing your legs from diabetes. So the complications continue to pile on the more you're sitting on that machine year after year. Avoiding that by getting transplanted early avoids those complications. Just like getting old, we all add to our risk of dying earlier, because our heart, our tissues, age. And so with age and with dialysis in particular, just imagine you're on dialysis every other day. And so you're gaining 5 pounds every day, and every other day you take it off. And so your heart gains it, your heart takes it off, and your heart gains it. And so you have this balloon on and off effect that gradually wears down your heart. And that's why heart disease is the #1 killer for patients with end-stage kidney disease on dialysis.
I think that's something that I really want to try and get writers to talk about, that little line in there about that, because I just feel like there's this sort of throwaway in Hollywood of like, oh, we'll put them on dialysis, and I'm wondering if people just that's sort of how dialysis has come back. Oh, well, I'll just live and die on dialysis. It's become normalized. And sort of what you're saying is what needs to become more normalized is that conversation of knowing what stage kidney failure you're in, earlier the better, and then having that conversation in your mind with your family, with your doctor about preemptive transplant, and kind of looking at dialysis as not just not something that is inevitable.
Right. Right. You know, the thing about it too is that we have to also realize that we have so many levels of disparities of healthcare. And part of that also factors into why people of color are diagnosed in the emergency room and late in the stage of their disease process, because you have to remember, these are silent killers, both high blood pressure and diabetes. You go monitoring your system, but externally or even internally, you may feel no different. But understanding what's going on inside of you and what it's doing to your system is important. So many people say, well, I've had diabetes for 30 years. Why am I just finding out that I have kidney failure? Well, where along the process was the ball dropped in terms of understanding? Or maybe it was mentioned, but the patient didn't understand the severity of what stage 3 disease is. Well, you know, your kidneys aren't doing that well. What does that mean? You're not doing as well? You know, well, don't worry about it, or allow that. And so my goal for education in terms of patients is to really and community, know your numbers, know what your hemoglobin A1C is, know your disease is progressing, know your blood pressure, know your cholesterol. Those things are important because you may not be symptomatic. Know your creatinine. And when you go to your doctor, check to see whether you have protein in your urine. So many times we don't do that. While it may be expected if you have diabetes, it's not normal to be spilling protein in your urine, but someone has to check for it. It's like saying, you know, I missed the diagnosis for TB. Well, you missed it if you don't do the test, right? So those things, and so the disparities in healthcare come about getting to a doctor. So many patients don't have a primary physician. Mm-hmm. You go from clinic to clinic and you see someone different, and so you don't trust the system. You feel this doctor was humiliating to you or didn't quite understand you, so you don't go back. You know, you say, I'm not going back there. He didn't treat me fairly, or he had some nasty comment to say, or whatever it is, or you just didn't, that patient-doctor relationship wasn't there and you didn't understand. Sometimes with my dad, before he passed on, I would say, well, what did the doctor say? And says, I don't know what he said. He gave me some medicine. What medicine did he give you? He gave me some pills. What are they for? I don't know.
Right.
And so that's where the breakdown can be, because oftentimes that communication didn't go across. And oftentimes we as the younger generation have to say, I'm going to go with you, or I want the doctor to call me so I understand what's. So involving family members, involving your loved ones, so you can gain a better understanding of your health and your kidney function, so that you know where you're headed. Do you need to be on dialysis? What does this mean to be stage 4? What does it mean to be stage 5? But you're not quite there yet, you know, knowing those things and understanding them.
It feels like this compounding effect of, you know, of the disparities and the implicit bias and the racism and all of these kinds of things. It's like this compounding effect that can lead people to, you know, just levels of distrust. Yes. Right? Levels of distrust with a physician, and with feeling like they're cared for and feeling like they're seen and understood, and really like the physician themselves wants the best for them, to the point where there's kind of an opting out of the whole thing, which can then lead to the snowballing effect of being at stage 5 and having to immediately go on dialysis. Right. I love the know your numbers there. I will put a little note out. The National Kidney Foundation has done a really lovely job with a short quiz that you can take. And we've included it at belikegina.org under Know Your Kidney Health. So you can take just a short quiz, and it will give you a sense of what your kidney health might be. Because even when we're talking about living donation, knowing your kidney health is sort of the first step of
Right.
even being a living kidney donor. You know, we were joking that if you want to be a living donor, like the best way to get $1 million workup physical, you want to know protein in your urine and everything else, say, I want to be a living kidney donor, because
Yeah. You're
those,
going to get a thorough workup. We want to make sure that you're healthy, that you have two functioning kidneys that's not going to deprive you of appropriate kidney function if we take one of those kidneys. And so that you want to make sure your heart's in good condition. The goal is not to have you die giving a kidney to someone else. You are the healthiest person who will undergo anesthesia for something that you don't need. If you think about it, you're doing that to help someone else. And so our goal is to make sure that we do justice and do no harm in having you go through a surgery as a donor to help somebody else, and to make sure that you are alive and can live a healthy life after donation. Someone asking the question in the chat, so when can you, at what stage of your disease can you get a living donor? And so the goal really is that once you have, if you are not ready to be on dialysis and you know you're in stage 4 to 5 or stage 5, but you're still hanging on there and you don't need dialysis, you can use that time to be worked up for a living kidney donor. And so intervention with donation is almost at the same time as if you needed dialysis, you have your donor ready, then your body needs that cleansing. You move straight to transplantation. So if you have someone on the list, they're not ready for dialysis, we intervene with that living donor when we say, okay, your EGFR is now less than 20% and you're feeling poorly and you're not doing great. So that 20%, which puts you on the table to be able, on the list to get to get a deceased donor, is when you would intervene for living donation. And that can be planned. So from that standpoint. And the other question was kidney disease. Will someone die from this? No, you will not die from kidney stage 3. Many people live at stage 3. If you take I usually tell patients, if you're a Caucasian older person with stage 3 kidney disease and you're being managed appropriately, you can actually live your life on stage 3 if your progression is very, very slow without even going on to end stage kidney disease if you're Caucasian. But if you're an African American, that stage 3 disease, if it's if you have a severe hypertension, may progress. So African Americans are 3 to 4 times likely to develop end-stage renal disease over the course of time compared to Caucasians. That's so important to know.
And is that is because of other health elements? That
A
is,
lot of it has to do with the severity of the high blood pressure and the consequences occur, the rapidity of which the disease process occurs over time. High blood pressure in an African American may take 3 and 4 or 5 medications to begin to control that high blood pressure, where for a Caucasian, they may only need 1 or 2 meds to control that. So the intensity of the hypertension is going to lead to more vessel damage and more clogging of those tiny blood vessels that perfuse the kidneys, and can often affect the brain and the heart, which you can have a silent heart attack or a stroke. And so those things are consequences of severe hypertension.
I don't think people really understand the severity of high blood pressure and all of the complications that it can really lead to. It seems like everyone's got high blood pressure and it's like, oh, that's just how it is. So this is, again, one of those things of knowing your numbers and asking the questions.
Yeah.
Should we answer a couple more of these?
Sure.
So average wait time for patients on dialysis before a transplant?
It's going to vary from region to region, depending on how many transplant centers are in your area and what's your population. And so if you are in a densely populated city with millions of people, then your waiting time is going to be much longer, because you're going to have many more people on that waiting list per area. But if you live in the remote area of Montana or Idaho, where there's a lower populations, then your wait time can be months to a year or 2. while in an inner city like California, New York, you may be 10 years waiting for a deceased donor transplant. So it certainly boils down to your geographic region and who you're competing against in terms of all the other people listed within that region, because most kidneys are allocated to the region first, to the local area before they're go out. So if you have a hospital and you're asking those around you to be organ donors, the goal is, yes, you can get a kidney from a absolutely perfect match from across the country, but your competition is going to be against those in your region.
You know, Tiffany talked about intersectionality, and I think that is one of, there's kidney surgeon Dr. Veal, who always talks about we're all pink inside, right? All
Yes.
kidneys are pink. And the idea that these kinds of donations can really go between race and ethnicity, gender. Obviously, there's size, there's HLA matching, there's blood type matching. So there are matches between, but those stories are so lovely and heartening, I think, especially in the United States, where we see that this kind of donation and gift to each other can transcend any of the barriers that kind of exist within our society. I know you said too, one of the things, like if you are, if I wanted to be a donor, a living donor, and I wasn't the same blood type, that's not, that shouldn't stop me, right, from trying to give
Right.
to my friend, because there's all kinds of things that transplant centers are doing to really get to maximize the possibility of living donation.
Absolutely. And one of the things that I'm going to take that step back somewhat is that I still listen to many people who say, I don't have any family members who are willing to give me a kidney, because in their minds, they're still thinking living related kidney donation, because we have said that for so many years. And so trying to get that concept across, that you no longer have to be related. You can be, if you think about spousal donations, you have the love for each other, but you are not genetically connected in any way based on your genotype or your genes. You just want to be compatible. So you're compatible in the sense that if you are blood type O and I'm a blood type O, I can give to anyone from that standpoint, because O can give to an A, can give to B, and can give to another O. So blood type compatibility is based on whether that is able to move forward. But if you have the other way around, and I need a kidney and I can only receive from a blood type O, and the person who wants to give me a kidney is a blood type A or B, then we can enter a donor exchange if it's not possible. And so we want to be able to say, if both of you are willing to say, yeah, and so for all donors coming forward, we usually ask them, as living donors, would you be willing to participate in a peer exchange if it didn't work out? Or there were antibodies that kept us from being compatible because my blood was going to be destroying your cells as a living donor. So now I'm going to try to find someone that I can match with that will then my loved one can give them a kidney. And that's how you get that chain effect, where you can then put this into the computer, and the computer says, well, why just do 2 people? I can plug in 4, 5, 6, 7 other incompatible pairs and see where the chain falls. And then you can have a whole system of Jane gave to Judy, and Judy's donor gave to Bob, and Bob's donor gave to Yvonne. And now you have a domino effect, which is wonderful.
Hollywood loves those.
Yes.
There's been several storylines, and one of them that received a DLH Inspire Award was a living liver domino, which actually I don't think has happened, but could totally actually happen. It was very much based. And the writer herself, her mother was a liver recipient. So it was lovely to see her take on the storyline and do so well with that. But yeah, Hollywood and television, they love those matches and those storylines and things like that. And I think it's worth noting, one of the things that I talk about often is the fact that, the reason why with Donate Leave Hollywood being a project of the OneLegacy Foundation, which is based in an organ procurement organization run the deceased donation system in a given service area. With so few people medically being able to be deceased donors, about 1% of people can be a deceased donor because of the type of way you have to pass away, and then also have kind of health within your organs. There's just no way to meet the list and the growing need for kidney transplants in particular. With 14,000 people on the list, about 99 to 100,000 are waiting for kidneys.
Absolutely.
And there's other research that I've seen that if you actually open that up and all the people who could be eligible to be listed, so people who are on dialysis who are not listed, you could be opening that up for the need for kidney transplantation to grow even greater. So at Donate Life America and with DLH, we're all sort of within the organ donation community looking at how do we start talking about living donation, because we're just simply not going to meet that need with deceased donation.
Absolutely. And we are not a country who we can move forward with the opt-out option. As you know, United Kingdom and Britain just moved to that system where you're a donor unless you opt out. And it does create more donors, but we are of a system where everyone wants to have the right to decide if they want to be a donor or not. And I think, when you think about the goal was to have 70% consent rate for organ donation. So many states are still below 50% in terms of organ donation rates. But the goal is to be able to have that ongoing education so that we can continue to bring more, at least from my sector, more African-American organ donors, more Hispanic organ donors, and also to understand and speak about live-in donation and have those discussions about, so that those fairs, just as we were able to make a dent in organ donation, deceased organ donation within the African-American community, we want to be able to say, what can we do to drive that education and drive a better understanding of the benefits of live-in donation? And, unfortunately, we have a tendency for, a lot of these disease processes to run in families, as we will bring in an African-American family, and, everyone has an issue, whether it's obesity or high blood pressure or diabetes or borderline diabetes, borderline hypertension, cholesterol high. Then you're given advice. So, these are the things you can do to make yourself a better candidate for organ donation. But that's also a limitation when you look at the discrepancies and the disparities of people of color finding appropriate organ donors, live-in organ donors from that perspective.
Right. Yeah, thank you for pointing that out, because yes, if you do have to be super, super healthy, because, physicians are going to do no harm, so they're not going to put somebody who could be at risk under the knife for something that isn't going to benefit them, then you're sort of creating inequity within within our communities of color. I think what's really fascinating to me, we have about 50% of the population in the United States who register as donors. And, that sticks at about, 50, 60%, 90% say organ donation is something that's good, right? So like almost everyone's like, yeah, it's a good thing. They just don't want to sign up. But then when it comes to actually consenting, the moment when an OPO goes in and has those conversations and has invested in culturally competent, requesters, people who look like the person that they're talking to, who speaks the language, that's a huge investment that the OPOs have made. We are seeing consent rates at 75% and above in Los Angeles, where we have a hugely diverse population, many people who are first generation who have never even heard about organ donation, but because of the way that that organ procurement organizations go in and talk to the families about this as an opportunity to really leave a legacy of caring for others. I always think it's so interesting, the number of people willing to sign up, but then at the end of the day, we see actually much higher consent rates or commitment to it.
Great. That's great. That's great
yeah.
to know.
Yeah, it is good to know. It is good to know. And in the United States, we don't have the opt out, but because we have opt in, we call people and say, register as donors, and then they can do that. And then if they don't register, we have a second option. We have 2 times that we can get people to consider this. Once, right now, we can all consider it, and then another time at the hospital after the family has heard a whole lot of information they don't understand, and then the organ procurement organization can explain it and walk them through that process. So I think that's part of what helps with the American system as well. I want to go back to your book for a minute, Beyond Every Wall, and because you not only have you overcome adversity, but I don't think you wrote this just to talk about yourself, because that's not the kind of lady you are. You did this to help others. And
Right.
because that's really what you've done with your whole life, is work to help others. So what did you think was important in writing this book? Like, why did you think it was important? Why is it called Beyond Every Wall? Talk about that a second.
Because, for me, there were many challenges throughout my life and my career and my aspirations to be what I wanted to be, and that was to become a doctor and a surgeon. And so many times there were these obstacles where I was told I, wasn't the best suited. I, wasn't the right color. My hands were too small. Women don't make good surgeons. And so whether it's my path or it's someone else's path, you have to understand that, and I always tell my kids, life isn't fair, and they're always going to confront obstacles. We're always going to confront that negativity. We're going to confront rejection. We're going to be faced with failure, but we can't let it bring us down. We have to see that there's another side to it, and that there's an opportunity to learn from this bad experience. And it's called Every Wall because, yes, throughout my book, I talk about different journeys that took me from one position to another. And there were down moments, and while I faced depression, and while I faced poor self-esteem, there were those positive moments too, where I can trust God, where I can turn to Him for guidance, and I'll turn to my family to say, help me get through this, or cry on somebody's shoulder, or have that person there to help me see that the positivity despite all the negativity. And so I tell people, we're going to face this. This is not just my story. This is everybody's story. It's just put on paper, whether it's rejection, whether it's implicit bias or microaggressions, or just institutional racism, or the negativity of people seeing you not as you want to see yourself, but as they see you, which undermines your culture and undermines your background, your ethnicity, and your ability to be who you want to be. And that's so very important. Even for people on dialysis, seeing alternatives to dialysis, of saying, I can't live like this. There's no way I'm going to stay in this chair and become complacent and think and give up. Don't give up. Don't give it. See that there's others who can do better. See that you can live beyond that chair. You can live another 10 years or 20 years or whatever it may. And yes, it may be challenging. Transplantation is not easy. It requires a commitment. It requires within your heart to know that someone gave you this gift, and you're going to treasure it, and you're going to take care of it because you were blessed to be able to receive this gift from somebody else. But you need to see those possibilities and not take no for an answer. And those are things that just examples of saying, I can learn through how my experience, and while this may be medical, is also a journey to say, yes, there are always going to be barriers in life. There are always going to be obstacles. There are going to be hurdles. There are going to be challenges. But how you deal with those, and how you using your determination and that positivity, and dismiss the negatives and say, there's got to be a better way, can keep you going. Trust God, trust whoever what is your source of inspiration? Try to find that source of inspiration that can keep you going.
And I think, my favorite My favorite movie is Legally Blonde, which I don't admit all the time. No, I do. I love it. But she says in the very last thing, she said, and always trust yourself,
Mhm,
right? And I think there's that element as humans, but as patients,
mhm.
to really trust that. And I think one of the things you had said too, if you're having a bad experience with a doctor, then find another doctor and trust yourself. Trust that this isn't the person that you feel is going to care for you. But don't just opt out. Don't just be
Yes,
like, okay, well, I'm not going to
I'm
go to
done.
doctors anymore,
Right,
right?
right, right. So many times patients will say, this medication, it does, it makes me lightheaded, or yeah, I feel crappy when I'm just not going to take it. And I said, well, did you talk to your doctor about it? Because if you're given this medication to help you, and you choose not to take it, he doesn't know he's going to just say you're non-compliant. Pick up the phone or say, doc, this is what it's doing to me. I need something else, or is there something else I can do? Lower the dose, figure out whether there's another alternative, because that doctor is out there playing golf or doing something else. They're not worried about you, but you're home feeling about the fact that this medicine is all upset about it. And so you ruined, or you contribute to your lack of better health by not taking it. But talk to your doctor, because you're the customer. Also,
Mhm.
you're the customer. You're paying him or her to take care of you.
Good.
So that's important.
Yeah, that's great. What would you tell any young African Americans who aspire to be a doctor?
If that's your goal, find resources, find mentors, find possibilities to make it happen. Reach out. And so many times I get requests to be, for me to be a mentor to someone, because they don't understand the path, or they want that encouragement. And if I can't do it, I'm gonna point you in that direction that allows you to be able to find that person, and give you the help that you need, because that's so very important. And don't be limited by your environment. Know that there are ways to bring yourself out of that environment to be able to do better, as long as you have that aspiration and determination, and seek those things that will guide you in that right path.
Yeah, I think that what I've learned from you too is really the importance of African American doctors,
Right.
because you threw out a fact, 13% of the population, but 30% of the waiting list, or 30% of and focusing on kidney disease. And this idea that we've talked about all throughout, the institutional racism, the bias, which may be implicit or may just be really external bias that physicians have in not looking at communities of color and investing and asking the questions of like, why the non-compliance, why didn't you go back? There can be those reasons why. And if you don't have a doctor that you trust, it pushes you further out and actually degrades your care and then your health, and then you're ending up in the emergency room having to go on dialysis.
Mhm.
And that kind of could all be, there's having more African American doctors really be with their patients, could give their patients, you said there was times too where you had patients who just were like, whew, okay, I feel like you'll
Yeah,
understand
and
me.
you're looking out for me. You said, Doc, you're looking out for me. I know as long as you're here, you're going to look out for me. And I think, one of the things we find is that there's so little resources. You think about people in the dialysis unit, social workers can help bridge those barriers and look at the issues around patients. But you have, unfortunately, the way the system is designed, there's just not enough. And you have one social worker maybe assigned to 3, 4, 5 different units. And it's hard to do your work or grasp or really get a handle around the needs of the patients if you are not able to spend enough time to deliver appropriate care. So, and they're looking, so it's okay to say, well, you're going to put these patients on the machine and dialyze them. What other help can be there to help them navigate the system? And that's where those people are important, to help them navigate the transplant list, figure out, helping them get their workup completed, those sort of things, to be able to get them on the list. So not only is it getting referred, it's getting through the waiting list, and is making it through the list, and then getting transplanted, and then needing the help after transplant. And those things are so very important. So.
Right. So we do have a couple more questions. I have a friend who's been on dialysis for a year and has one kidney. Can she live a long life?
I'm not sure if that kidney means she got a donated kidney. Yeah, but certainly if you have a kidney transplant, you only need one kidney when you get a kidney transplant. For some reason, God gave us two, but we really can live with one. And transplant patients live with one. And a small percentage of people are born with one kidney and do just fine. So yes, you can live with one kidney. So transplanted kidney, you have to make sure that you're taking your medications and be monitored for rejection. But there are people who do well at 10, 15 years post with the kidney transplant.
And isn't it true that if you get a kidney transplant, you actually don't have one, you have three? Because if you were born with two and your kidneys fail, and then you get a transplant, you get one kidney, and they don't take your other two kidneys out, do
No,
they?
we don't normally take out the other two kidneys unless there's something wrong with them. You may be, but if you're on, maybe make sure, and that's why we do tests and CT scan and ultrasound to make sure those kidneys don't have any abnormalities or cancer or something that warrants intervention. But no, we leave those kidneys. Over time, they do get smaller and smaller. And even if you're on dialysis with not using those, not with the ability of those kidneys not working, they will shrink down and get smaller. But yes, you will have your own two old kidneys in there, and you have the third kidney. If you get a second transplant, now you'll have 4 kidneys.
See, and then it can be like two truths and a lie, and no one will think that that is your truth.
I think about that. Yeah, 2 truths and a lie. Yeah.
There's another person talking about donating to somebody who may still be smoking or drinking or eating poorly, feeling like you sort of need to be giving a kidney to a family member, but then also looking at their lifestyle and wondering, I don't know if I want to give to somebody who doesn't necessarily look like they're taking care of themselves. But I'm thinking that there's so much that goes into actually listing someone, that if you are not showing signs that you're caring for your body,
Right.
that you wouldn't even get listed. Because even though you can get a preemptive transplant, you still have to get listed to
You
be
still have to
able to
qualify. You still have to meet the criteria, and you still have to show, if you're not willing to do the things that are necessary for your own health and for your own longevity, even before you get a transplant, then we're not sure if you're going to do what's in the best interest of valuing that gift so that you can live a better life when your life is already at jeopardy based on your inability to see the importance of taking care of yourself.
So you've probably seen people just with like obesity, for example, where if people would need to lose weight before they could get listed, and then also people who would have to lose weight before they could be a donor, a living donor. Is that right?
Right. Yeah. There are many programs who have increased the BMI guidelines so that obesity in itself, depending on the distribution of your body habitus, is not always a limiting factor in receiving a kidney. But certainly for a donor, we want to make sure that that's not going to compromise your health later on in your lifetime because of obesity and having one kidney, and putting a significant strain on that single kidney after you become a donor. So those things are taken into consideration to make sure, yes, you can give that kidney, but you want to make sure that your body's not going to suffer in having that one kidney take care of your system after donation.
How do we get more information to dialysis centers to educate patients about getting on the list? What can we do to make sure that the patients themselves are saying, hey, why is no one talking to me about transplant? Let's talk about transplant.
there is, CMS does require that patients on patients on dialysis be educated about transplantation and be given that information. So it's really important for the dialysis unit and the physician's office and nephrologist who is having those seeing patients even before they get to dialysis to educate them on the options of treatment of end-stage renal disease, tell them about transplant, tell them about dialysis, not only hemodialysis, but peritoneal dialysis. If they get to the dialysis centers, then it's that dialysis centers are responsible for evaluating all their patients to see whether they're candidates, appropriate candidates for transplant, and now referring them to a transplant center and leaving it up to the transplant center to then decide if they're appropriate candidates. Yet certainly we don't, if you send in an 85-year-old to be referred for transplant evaluation, that may be on that may not be necessarily appropriate depending on their comorbidities or the stipulations of each transplant center may have the age requirements, but they're still committed. They're still responsible for referring dialysis patients to transplant centers to be listed for transplant.
The television show Be Positive on CBS, it is not fully beloved by kidney patients because they don't really show fistulas and they sit in a dialysis chair and it all seems a little too easy, right? Yeah. And so there's been concerns. I'm like, yeah, but if you saw the very first episode, the main character, Drew, gets his test results back and immediately his primary care physician says, you're in kidney failure. You're going to need to get a nephrologist. Here's a nephrologist and consider living donation. And I thought, whoa, if this show did nothing else besides put that conversation of bam, bam, bam together, right, so that people start to think about the two things together, not just nephrologist dialysis, but nephrologist living donor. Because he's like, right, you probably need a transplant, consider who you can ask in your life as a living donor. And again, that was to set up the whole sitcom. Right. But I thought, wow, if we could start to model that behavior so that even at the first step of your primary care physician, there's some conversations. I do want to, we're almost out of time. I will ask Tiffany to jump back on because she told us that she has a pressing question that she wants to ask. So we have to bring her back into this conversation so she can ask her pressing question.
There you are.
Well, Tanaya, you asked my question already. I wanted to know, what would you tell young girls that are growing up that want to be a doctor or even transplant surgeons themselves? And Tanaya asked that, so thank you, Tanaya.
I have a pressing question then. I thought this was going to be your question, so I didn't ask it. But I want to know that when Donate Life Hollywood makes the movie about Dr. Scantlebury's life, who is going to play Dr. Scantlebury? What do you think? Who do you think should be cast as you?
Oh, I have no idea.
You put her on the spot.
Oh, geez. In Black Panther.
Okay.
Any of those women in Black Panther, they can play me.
Okay, good. All right. Well, see, that was my pressing question. I was like, who do we need to be casting? Because your story really is, I don't know, it feels like a movie script to me. And I'm just so grateful that we got to spend an hour together with all of your information, your energy, your commitment to caring for all of your patients and really for communities of color, to bust through biases and to see equity and to really champion changes that need to be made.
Absolutely. Thank you so much for having me. This has been a wonderful experience. I hope that others have find it informative. It's a great opportunity. Thank you so much. And I hope you get my book soon.
Absolutely. And I just want to chime in here and say, I am inspired and empowered personally by your story, Dr. Scantlebury. So thank you for sharing it. Thank you for educating our communities of color. It's very important and personal and dear to me, as it should be to many of us. And for everyone that's watching, I want to, remind you guys that we want to engage with you. We want to make sure that we're providing tools that are necessary, that can educate you, that can ultimately help you thrive and live a healthy life. So I want to repeat what we've heard several times throughout the town hall: know your numbers, get checkups, know your kidney health, know your health, and you will ultimately help you and your family. So if anyone wants to register to be organ, eye, and tissue donors, at the end of our Zoom call today, you'll actually have a survey that you can fill out, and you can register to be an organ, eye, and tissue donor. You can find out more information if you want to know more, but let it not stop here. Let this be the beginning, and know your numbers. Thank
Thank you
you.
so much.
Thank you.
Thank
Thank
you,
you, Kanaya.
Yes, thank you. Thanks for having me.
Thank you. Thank you. Wonderful opportunity. Thanks.